and so on and so forth. The institute is famous for research in infectious diseases, particularly malaria, for which has been designated a center of excellence in Africa, and also non-communicable diseases, including breast cancer, sickle cell disease, stroke, and dementia. Numerous research and administrative units, and I will just mention some of them. We have genetic unit, we have epidemiology and biostatistics research unit, palliative care unit, neurodegenerative research unit, and then the institute is also playing host to the University of Ibadan University College Hospital Ethics Research Committee, a top research ethics committee in Nigeria that was established in year 2002. At this junction, let me hand you over to the director of the institute, Professor Ikeluapo Oajayi, who will give us opening remarks. Thank you very much. The director, ma'am.
Good afternoon, everyone. It's another day for the IAMRAT lecture. You are all welcome. I join Mr. Adeniji in welcoming everyone to this lecture. This afternoon, we are going to have a talk from our erudite professor, Professor Adebola, Orimadegun, professor in the Institute for Child Health of the College of Medicine, University of Ibadan. He's a pediatrician, and he has worked extensively on febrile illnesses amongst children, looking at malaria and other causes of febrile illnesses. There is going to be the citation will be read soon, so I don't need to say much about that, but to thank Professor Orimadegun for accepting to give this lecture, and more so at this time that we know that there is a lot of issues with pediatric febrile illnesses in our country. And just recently we had the diphtheria outbreak in the secondary school, for that matter. Usually we see diphtheria amongst younger children, but we can see that it is very important that people get to know more about the febrile illnesses, and to also tell us what he's been doing and how his work has impacted interventions have been translated into policy. So I would say, sir, Professor Orimadegun, you are most welcome, and we are very grateful for your support to the Institute for Advanced Medical Research and Training. I will hand over now to Dr. Bakari, who is going to read the citation of Professor Orimadegun. Thank you. Thank you. Dr. Bakari, please. Dr. Bakari, you are muted in case you started reading the citation. You are muted. We can't hear you.
Okay, thank you, ma. Good afternoon, everyone. My name is Dr. A.S. Bakri from IAMRAT, I'm to read citation of Professor Adebola Orimadegun, our guest lecturer for today. Adebola Emmanuel Orimadegun.
Just a minute. Professor Orimadegun, please kindly
Yes,
let's see your photo. Are you with us?
Yes, I'm with you.
Okay, thank you. Please go on.
Okay. Adebola Emmanuel Orimadegun is a professor of pediatrics and child health at the University of Ibadan. Professor Orimadegun's journey in the field of child health and public health has been marked by a deep commitment to improving health outcomes, particularly in children. With an academic career that spans over 16 years, Professor Orimadegun has established himself as a leading voice in the research and practice of child health, pediatrics, and epidemiology. Graduating from the University of Ibadan, Professor Orimadegun pursued his medical degree with a passion for bridging the gap between clinical practice and public health. He earned 2 Master of Science degrees in epidemiology from the University of Ibadan and in clinical trials from the London School of Hygiene and Tropical Medicine, University of London, which he completed with distinction in 2005 and 2013, respectively. He obtained a PhD in epidemiology from the University of Ibadan in 2017. Professor Orimadegun rose through the ranks, becoming a senior research fellow in 2011, a reader in 2014, and a professor in 2017. Professor Orimadegun's research has significantly advanced our outstanding understanding of childhood illnesses, particularly malaria and nutrition. His studies have been widely published in high-impact journals. He has over 120 well-cited publications with H-index of 30, according to Google Scholar. His work has not only contributed to the scientific community, but has also informed public health policies and intervention programs in Nigeria and beyond. In addition to his research, Professor Orimadegun has held several key academic and administrative positions. He is currently serving as the director at the Institute of Child Health, University of Ibadan, where he has mentored several students and young researchers. His dedication to education is evident in his role as a supervisor for 35 undergraduate dissertations and theses to date, many of which have gone on to become significant contributors to their respective fields. He is currently supervising 7 PhD candidates spread across 3 universities in Nigeria. Professor Orimadegun has received various research funding, notably from TED Fund, through the University of Ibadan, Malaria Consortium, Williams and Flora Hewlett Foundation, WHO, Management Services for Health, MSH, USAID, the Institute of Education in the United States, APHRC, and Bill and Melinda Gates Foundation. He has also garnered international recognition with 3 funds from major organizations such as WHO, APHRH, and the Institute of Education in the United States. His expertise is in demand worldwide, and he has acted as an external examiner for several universities in Nigeria and abroad, including the University of Cape Town in South Africa and Wageningen University and Research in the Netherlands. Professor Orimadegun has received numerous awards and accolades for his outstanding work, including the prestigious Best Nigerian Pediatrician Researcher of the Year 2022 award from the Pediatrics Association of Nigeria, PAN, for outstanding contributions to maternal and child health in the sub-region. His dedication in medical teaching and research is unwavering, as evidenced by his position on many boards of organizations, university and hospital committees, including University of Ibadan's Senate Development Committee, the College of Medicine Curriculum Committee, and the University College Hospital Research Committee as chairman, as well as international organizations such as the World Health Organization and Friesland Cambrian Institute. He is a member of many learned societies, including Pediatric Association of Nigeria and Nigeria Medical Association. Since 2019, he has served on the board of Ekiti State University Teaching Hospital. He also serves as an elected member of the University of Ibadan Health Services. His work with the Institute of Child Health, as well as his leadership role in child health research and education, demonstrate his enthusiasm for teaching and mentoring. Professor Orimadegun is married with children. Please support me in welcoming Professor Orimadegun as he presents his work. Over to you, sir, Professor Orimadegun.
Thank you very much. Good afternoon, distinguished colleagues, distinguished ladies and gentlemen. I want to appreciate the Institute of Advanced Medical and Training Research and Training for the opportunity being given to me to present today's lecture, which I have titled Bridging Science and Practice. I will be illustrating this topic with some of the modest contribution my colleagues and I have made towards improving child health and specifically diagnosis and treatment of fever, depending on where you are. This internet connectivity. Thank you. Distinguished ladies and gentlemen, you will agree with me, fever is one of the commonest and, in fact, almost the most common reason why our children present in the hospital. This topic is very dear to me. Research could achieve not just knowledge for academic journals, but will measure in our communities. Illness continues to claim the lives of our children unnecessarily. Today, I'll be speaking on this topic, and I'll be using some of our study to make illustrations on how research can get translated, and we can move from basic science research to clinical and then implementation research. Before we dive into this lecture, let me quickly share why this topic is important to me and why it should matter to all of us working in the areas of child health, research, and policy. For many years, my colleague and I are focused on improving how we diagnose and manage febrile illnesses in Nigerian children. In our setting, fever is one of the most common reasons children are brought to the hospital and clinics. But for too long, the default response has been to treat every fever as malaria, often without any test. Over time, our work and the work of many others across Africa has shown that, but they are also dangerous. It leads to misdiagnosis, it leads to overtreatment with anti-malarials, and worse still, it allows serious bacteria and viral infections to be treated undetected or very often left untreated. My modest impact in this space has been contributing research that questions this long-haired malaria-centric, a more evidence-based, that together with my colleagues, diagnostic tests, compare them with microscopy and polymerase chain reaction, PCR, and provide data showing that non-malaria fever or non-malaria infection account for a significant proportion of fever in our children. Ladies and gentlemen, for today's lecture, it is an exploration of how translational research can truly transform fever diagnosis and ultimately improve outcomes for African children. By the end of this lecture, it is my hope that I will have illustrated how scientific research bridges the gap between laboratory discoveries and real-world healthcare practice, with a particular focus on fever diagnosis in African children. Second, we will evaluate the performance of malaria rapid diagnostic tests and discuss what that means to clinical decision-making in our setting. Thirdly, we will analyze how research findings, including some of our own work, have influenced policy reform and clinical guidelines. All of these will be aimed at promoting more effective fever management and improving child health outcome. Next, we highlight some of the major challenges we face in translating research into practice. Things like resistance to change, limited diagnosis infrastructure, and of course, funding constraint. Then we will advocate for unsustainable solutions and sustainable solutions rather, including promotion of local diagnostic manufacturing, public-private partnership, and increased government investment in research and development. And finally, we will explore future direction, particularly the potential of digital health, artificial intelligence, and regional collaboration in revolutionizing fever diagnosis. The burden of febrile illness in African children is enormous. Colleagues, let us start by appreciating the scale of the problem that we are dealing with here. Fever is the most common reason children are brought to healthcare facilities. As I said earlier on, it will account for as many as 60% of outpatient hospital visits in Nigeria alone. This means that every day, thousands of our children present with fever, and clinicians must decide, often with limited tools, what the cause might be. Historically, we have equated fever with malaria in many settings, and rightly so, because Nigeria contributes as many as 20% of malaria deaths worldwide. Malaria, as we all know, is a leading killer, especially of our under 5 children. However, recent events have shown that things are changing. Malaria incidence is declining in many regions, including Nigeria, thanks to the control efforts by WHO and our local policy makers and governments. Yet, till I'm talking to you now, fever persists because malaria is no longer the only cause, nor in many cases, the primary cause of fever. So, I am presenting this lecture mainly because of the high burden that we have had to deal with concerning making diagnosis of fever and the challenges that we face. Talking about challenges in diagnosing fever in Africa. Now let us establish this and examine using some of our studies. First, there is a historical assumption, like I said earlier on, that fever is equal to malaria. And for decades, this has been the practice. And it has shaped how we manage fever, particularly in our country, Nigeria. Why this may have been justified when malaria transmission was high. Diagnostic are scarce then, but we now know excuse that the ability of simple and easy to learn. Many facilities like reliable microscopy and diagnostic tests, some settings, especially there's often no capacity, bacteria and viral infection in many settings. The situation is fueled by antimicrobial resistance because clinicians cannot confirm the cause of fever. The default is for them to prescribe empirical antimicrobial treatments. And this has really worsened our situation with respect to antimicrobial resistance. There is also the economic burden of malaria. For example, studies from Mozambique and other parts of Africa countries have shown that misdiagnosis and repeat visits to the hospital due to unresolved malaria episode can drain household resources, prolonging suffering of the children. We must therefore recognize that the knowledge and behavioral gap among health workers and among mothers who bring these children to our clinics need addressing workers and researchers towards nipping this on the board. Colleagues, let us examine one of the most critical risks we face in fever management, which is over-reliance on rapid diagnosis. RDT. There is no doubt that RDT is easy to use, but the challenge of causes of fever that are younger than 5 years. We found that 37.2% of febrile illnesses tested negative for malaria in one of our studies. 54.7% had viral infection, yet sometimes could be very severe if not managed properly. What does this tell us? It tells us that relying solely on RDT creates a false sense of diagnostic certainty. We risk missing children with potentially life-threatening bacterial infection simply because the malaria test was negative. And we know that why this happens, false negatives due to low parasite density or poor storage of RDT kits will also occur. We also know that false reassurance may happen to no guidance to know what to do. This is dangerous because it means children with conditions like pneumonia, like sepsis, are sent home untreated or misdiagnosed. The implication is very clear. While RDT remains valuable, they are not enough. We must expand our diagnostic thinking, and we must develop broader diagnostic protocols that cover bacteria and viral infection. Colleagues, this is the art of the challenge in fever management in African children today. Now, this brings us to one of the most important findings from our study. What exactly is causing fever in children when malaria has been ruled out? In our study of 511 febrile under 5 children, we tested negative for malaria using RDT. We set out to answer the following questions. What we found was both revealing and concerning. We found out that 54.7% of the children had viral infection. This included common respiratory viruses and others. Others can cause serious illnesses if not monitored and properly managed. 32.1% had bacterial infection. And this is where the real danger lies. Urinary tract infection, skin infection, otitis media, and bloodstream infection, septicemia or sepsis. Conditions that, if not that, and treated, or even death. Landscape in African children has shifted. Malaria is still important, but it is no longer the only cause of fever, and it is no longer the most common cause of fever among our children. Our translational approach for malaria positive enough anymore. Body or bacteria, even more deadly, sometimes in young children. Colleagues, these findings, they tell us that every time we see a child with fever, especially when malaria test is negative, we must think wider. We must consider other infections and, if possible, test for them. This is the cross of integrated fever management. Because if we are serious about reducing child mortality for purpose of translational research. Distinguished colleagues, ladies and gentlemen, what is the purpose of translational research? Simply put, it is to ensure that what we discover in the laboratory is in academic papers, in scientific studies, does not end there. Too often, research findings remain trapped in journals, gathering dust on library shelves. Many of our students' work only gather dust in our general library, and they never get translated. They never become evidence that can be used. Translational research breaks that barrier, ensuring that scientific knowledge is applied where it truly matters. In clinical setting, in public health programs, and health policy generally, translational research is key. Knowing that and developing and validating new diagnostic tools, and then training healthcare workers to use these tools appropriately, and finally influencing policy and guidelines is managed in real life. The ultimate goal is simple, but it has profound impacts to improve patient care, and health outcomes, which is often the target of most of us who are clinicians. In our case, to reduce the number of African children dying or suffering from misdiagnosed febrile illness because the right tests were not or does not. It is a moral imperative. If our research does not translate into saving lives and improving health system, we have not truly finished the work. And I think this is a good take-home point. Even if I end the lecture at this point, I have made a very important point. But let me go further and talk more about translational research and then illustrate how our modest contribution and aspect of our healthcare practice. Translational research stages. Translational research can be broadly looked at in 4 stages rather. Stage 1 being the basic research, and stage 2, clinical research, then stage 3, implementation research, and lastly, 4, policy translation. Begins. Here we seek to understand the biological of disease. For fever, for example, this means asking what pathogen is actually causing this fever? How common a bacterial infection? What do the virus do to the body? This stage helps us to identify the knowledge gap and need to be addressed. Two, at this stage, we take our discovery from laboratory and test them in real-world healthcare settings. We validate diagnostic PR, microscopy, etc., and then assess their performances. This is where we determine whether these two work just in theory, but in the hands of healthcare workers, in our clinics and in our hospitals. Stage 3 in translational research is often the hardest part. Here we focus on integrating research findings into actual clinical providers to train them on understand the barrier they face and find out and behaviors or pattern of susceptible people that aid or determine to know what works. It is used correctly and consistently. The last stage of translational research is the policy translation. This is the most impactful stage. Taking the evidence and ensuring it informs policy, national guidelines, and system change is very crucial. This is where we influence government, funders, and health system to scale up what works and abandon what doesn't work. Colleagues, as you see, translational research is a journey from the lab bench to the bedside and all the way to policy makers' desk. Every stage is critical if we are truly to transform fever diagnosis and improve child health outcomes in Africa. Still talking about basic research, I would just simply like to do this aspect with our work. This stage is important because it tests whether the solution developed in the lab can actually work in the environment. Whether it can work in the environment. For our research, This meant evaluating the performance of malaria rapid diagnostic tests in actual field condition, comparing them to microscopy, PCR, which are considered the gold standard. We studied febrile children between age 3 to 59 months in Ibadan, Nigeria rapid diagnostic test brands. We found out as follows: that SD bioline RDT compared to microscopy, and there was variable specificity, but when it came to specificity, the ability to rule out malaria when the child, when the child didn't have it, the RDT struggle ranging from 72 to 74. Why? Because HRP2 antigen can linger on in the blood even after malaria is cleared, leading to false positive. We also observed some reduction in performance compared with PCR. The RDT missed some low-level infection that PCR was able to detect. And this is a reminder that no test is perfect and context matter. The key takeaway from this study is that RDT are useful, but they are truly not foolproof. And we still face the challenge of not proving that malaria, that fever is not always malaria, even with RDT. And this implies that clinicians must go beyond just RDT and find out the causes of fever whenever RDT is negative. So the value of clinical research in this setting is that it revealed the strength and limitation of our tools in the hand of frontline healthcare workers. And it remained in the RDT, especially when the test is negative. We went for to do some research to evaluate the case study, the contribution of clinical research to translational research. Our key findings in this series of study show that 60.5 rather of tested positive, 0.5 tested negative. Was critical and reassuring is that there was no increase in malaria risk in the RDT negative group, even after 28 days of follow-up. We follow up the children up to 28 days, and we continue to test them to find out whether they turn out to become positive again or remain negative. And we found no risk of malaria after RDT negative. So, and that is very reassuring. However, we also found that children who were RDT positive had a higher risk of infection even after treatment. This was likely due to high transmission. Out also that anemia was more common in malaria positive cases. About 37.9% of those children had anemia, reinforcing malaria's role in childhood morbidity. Sensitivity, as I told you earlier on, for RDT was good enough, but specificity was relatively lower. What are the implications of our findings? First, they validate that restricting malaria treatment, especially using artemether-based combination therapy, poses no risk, and it is both safe and feasible. And finally, our study demonstrates that the power of translational research, showing the evidence-based diagnostic-driven treatment can safely guide malaria management without harming the children. Colleagues, this example I'm giving you are real-life examples, but we've been able to investigate the reliability of only use RDT, and we have been able to show that health workers run as only RDT. One thing with child who present with fever and turns negative deserve to be further investigated. Policy recommendation. Based on our findings and the challenges identified diagnosis and management, here are some of our specific and actionable policy recommendations. Is to refine malaria treatment guideline, and then children time, malaria treatment guideline and treatment of fever generally are reviewed or revised based on evidence from translational research. Our research has shown that too often, clinical attention stops once malaria is ruled out. Children are either sent home or given unnecessary antibiotics without any further diagnosis. Therefore, policy must now mandate that when a child tests negative for malaria, clinician must continue the diagnostic process, looking for other causes of fever. Secondly, there's the need to invest in and promote multi-pathogen disease diagnostic. It's time for our government policymakers and think of multi-disease diagnostic tool. For example, what if we invent a diagnostic tool that can detect both bacteria and malaria at the same time, or that can detect and make a distinction between bacteria and viral infection in children who have febrile illness? This will improve diagnostic accuracy and allow clinicians to treat the right disease, reducing mortality and reduce rational use of drugs. Thirdly, there's a need to strengthen public-private partnership to engage local manufacturing of diagnostics. And this is it.
Orimadegun.
Yes, ma'am, back.
Okay.
Okay. Can you hear me? Thank you. So I was saying that there's a need to harmonize regulatory framework across African countries. Regional harmonization is key to making sure diagnostics can move easily across borders. And this will enhance cross-border trade, ensure quality control, and improve access to life-saving diagnostic tools in remote and underserved part of Africa. We also need to consider institutionalization and integration of fever management protocol. Policies must embed integrated fever management. I am aware of we need to put things in local address the issue of. Now, talking about future direction, where do we go from here? It is important for us to think about, not only to think about the challenges, but there's no doubt that for us as researchers, policy makers, and everyone who has role to play in management of fever in children, we should think about enhanced point of care. We should begin to think about biomarkers that can help us to make distinctions among the different types of. They need to set up multi-complex and multi-pathogen diagnostic tools. The future must move beyond RDT. The future already has moved beyond microscopy, but we need to move beyond RDT now. We need point of care diagnostics and diagnosing accurately. Research. Another promising area, another inflammatory markers. Though some of these are already in use, we need those that are context specific. There's a need for integration of artificial intelligence into and digital health solution. As digital technology advances, AI-powered decision support system could revolutionize fever diagnosis. Imagine a system where a symptom, vital sign, and test result and risk factors are combined to guide clinician towards the most probable diagnosis, all by the bedside. It will be very good and most likely more accurate than just guessing. It need to strengthen regional research network and collaboration. We need to work more with one another, particularly basic scientists. Also need to move beyond just publishing our work in journals and think about how research can translate to policy decisions and get information across to policymakers. And let's begin from our local environment, and then before we begin to think of international. For us as researchers, it is important for us to think of solving local issues first before we begin to seek international recognitions. Conclusion. I would like to conclude this lecture by saying that fever in Africa is not just malaria alone, and that basic research, as simple as the studies we have carried out here in Ibadan, will be, we have brought out some translational components. Our research have informed review of malaria guideline in Nigeria, and it has also contributed to the data that have been used for in recent review of the treatment guideline, there's a need to expand that in order to capture bacteria, viral infection, and viral infection. We need to invest in multi-pathogen diagnostic, both locally and internationally. And let us also, as we depart from this lecture, from here, think about what is next in relation to febrile children in Africa, especially in your own field and your area. What will you be willing to contribute that can bring about translation of the research we are doing in our local environments? These are my references. I thank you all for your attention. Over to you, Ma.
Wow, thank you very much, Professor Orimadegun. It's been a brilliant lecture all the way, and thank you so much for sharing your passion with us. The research work which you have done has actually done a lot in terms of translating some of your findings into policy. I know you work with the NNEP too. Let me ask Dr. Bakari, would you be doing the question and answer session? Dr. Bakari, please. Okay, the floor is open now for questions. So you can either raise your hand using the tool or you write your question in the chat box. Thank you. I'm so happy we have over 100 people with us because I think one or two had just dropped. So that's a good one. Please, we have many malaria experts amongst us. We'll be happy if you want to contribute and share your experience. Oh, there are so many hands up. Oh, good. Sorry, I don't know who did first, but let me call Dr. Adebola, followed by
I want to appreciate the Professor for that succinct presentation. I did enjoy it, yeah. I want to ask, what local intervention did Professor use and what make the research translational? What local intervention? Because one of the recommendations is that we should come back home and look at local material that we can use to solve this issue of children malaria. So did this research experiment with particular local doses, and what really make the research translational, sir? Thank you very much, sir.
That you go from basic to practice and then to
Prof, do you want people to ask, maybe a couple of people to ask their questions before you respond, or you do it one after the other? Prof,
it's okay to have it's okay to have more than one.
Okay. I believe I want to thank our National Malaria Elimination Program people. They are on ground here. We have the current national coordinator of NMEP, Dr. Nelson Eze, and then the immediate past or immediate former national coordinator, Dr. Chukwu. They are both here. So, Oga Nelson, please, could you ask your question then? Dr. Chukwu, please. Thank you.
Okay. Thank you very much, Prof. Thank you. The two professors, the presenter and the Professor Jaida's accurate.
just to say, Prof, thank you very much. But I am not the national coordinator anyway. I'm just the head of surveillance, monitoring, and evaluation.
Sorry, head of
MIE.
Yeah, head of MIE. Sorry for that.
Exactly. Yes. When another meeting, myself and Dr. Chukwu, we just finished that meeting and we saw the need to quickly join. Our late joining was not intentional. Please, as I said, let me apologize, because I know you sent this invite almost 4 or 5 days ago. So it wasn't intentional joining late. And also to let the team, everybody know that NMEP is strongly behind such presentation and policies, this type of gathering that will bring forth interventions that are aimed at eliminating malaria in Nigeria, and but particularly some of these modeling interventions, that because without modeling and some of these key presentations like this, we may not have a focused intervention mixes, because modeling comes with data. And from the data, of course, gives rise to modeling, and from that modeling, we now have focused area of intervention mixes. Just to pledge NMEP's support and collaboration to organizations and individuals who are making this significant effort in bringing forth areas of focus like this in terms of presentations or workshop. Let me stop here so far and hand over to Mr. Chukwu for his own comments. Thank you very much, Prof, and others. We're also available to make, maybe at the end of the meeting, also to make some comments again at the closing remarks. Thank you very much. And over to you, Mr. Chukwu. Over to you, Prof.
Yeah. Mr. Chukwu, please. Please unmute if you are if you are asking any questions. Unmute, please. What happened? Okay, any other, while I try and sort Mr. Chukwu out. Any other person who wants to ask question?
Okay, so it's now that you gave the opportunity, because I couldn't unmute. I was trying to unmute, and then it says the host is not allowing me to unmute. So that's the reason why I couldn't unmute. So thank you. Excellent presentation by Prof. Great one. So a few comments, or rather questions. Issues about overdiagnosis, especially when it comes to malaria, is one of the things we are battling with. And that is why we are having high test positivity rates across the country. And we know already that what is being reported as incidents in the country might be well below what is, this thing. So it is something that we indeed, including some wrong use of RDTs, as it were. But I just want to ask, Prof, number one, do you have some information on data on the percentage of the tests that were conducted using RDT and were classified as negative that were actually positive? And how did you, if you did, how were you able to do that confirmation? Two is, you mentioned about integration of AI, which I think is a good way to go. But I am looking at how do we, especially for, be specific for malaria, what additional measures? Is it just a question of capacity building, or is it a question of integrating another tool, which we tried at some point in time? We had a study where we had some panels that were utilized, and then we were able to compare the results from those panels with what the health worker read, and we discover some levels of discrepancy, but not too significant. So we'll be wanting to hear your thoughts on the way to go on this and how to be able to validate some of those issues as a routine measure, not as a study. The third thing that one is looking at in this context, we see your recommendation on the integrated fever management, a good way to go, definitely a good way to go. My question here is, to what extent can we be able to make this happen? Because unless you want to stop at some point in time where you have to make referral, but if you want to extend it to what will be done after testing, and then you go on to what needs to be done, I don't know where you will need to stop. Maybe you might give a clue in terms of that, because there are so many things, conditions and diseases, that fever is a start point. So to what extent, without being over bulky and without being too, these things, remembering, and this is where I'm going, that most of the facilities we are talking about, health workers we are dealing with, are people in the PHCs where majority of cases go to. And these people are not medics in terms of, they are not even nurses. Maybe they are community acutes. How can we be able to manage that kind of a process? So I think that's where I want to stop. But again, my interest lies with the point of care, diagnostic methods you are bringing up, which has been a good way to go. Again, the question is, what are the critical areas? What are the critical diseases based on your findings you might want to prioritize when you are looking at point of care, in case somebody wants to look at that for other issues that fevers is the starting point. Over to you. I hope I'm clear. Okay.
Do I have the floor to respond?
Yes, please go on, Prof.
I thank everyone that has asked questions, and I see there are still many hands up, but let me quickly respond to the questions already asked. But before I go on, I would like to acknowledge a few of my trainers, mentors, and colleagues, and many of whom I've worked with in this area. They are online. Professor Falade, Kitri Falade is one of them. And even Professor Ajayi, they are a member of the team. And Professor Adebola, many, and I can see Dr. Adanzi Asinobi stands up. And many of you, I'm not able to mention your name. I acknowledge you that many of the things I've said concerning our study here, there are people who contributed to them online in this lecture now. And I'm very sure maybe they would like to make one or two comments after me. The question on what intervention did we use to manage the cases we investigated? I presented just one community-based study because I had the challenge, a major challenge of how to put in many of the work we have done together on the feed to illustrate this case. So I decided to choose the study we carried out to investigate consequences of restricting malaria diagnosis to RBT use only. So we treated those children with artemisinin-based combination therapy, specifically artesunate, amodiaquine. And those who did not, who had negative tests, had appropriate antibiotics where necessary. We also attempted some viral testing, and then we made diagnosis based basically on clinical symptoms and signs with some laboratory testing. The studies are already published. If you want to know detail, because the time allotted for this lecture was not enough for me to present all the data from that study. The references as in my PowerPoint, you can download the papers and read. But as I said, we treated those children with already established anti-malaria approved in the National Guideline for Malaria Treatment in Nigeria. We did not develop any new local treatments, and we did not, test any laboratory tested materials at all, but already established treatment, because the overall aim of that study was to show that there's no need to be afraid of using RDT. But in the process, we're able to establish so many other issues, namely that a reasonable number, a remarkable number, were actually not malaria. And those who tested negative require further testing. And those who tested positive to RDT should be given anti-malaria as appropriate. And those who did not test negative, who tested negative, require further investigations. And we also was able to establish the fact that, contrary to the opinion and fear of many of our colleagues, that RDT may not be sufficient to make malaria diagnosis, testing with RDT and treating such child did not predispose the child to any further risk of malaria over the next 28 days. Those were the, that's the summary of some of the findings. Then there's a question on, what makes the research translational? Okay, the research was actually a longitudinal study with many components. I presented two of the components to you. One of the components that makes it basic research is the fact that we tested RDT, compared many RDT in the same study. And in the same study, we tested the outcomes of treating malaria over a period of 28 days. And that was a lot of work for us. So we could, at first hand, investigate and know exactly what patients are going through in the hands of healthcare providers outside of the teaching hospital settings. So the translational component is that we were able to generate information that can be used for policy to educate and train primary healthcare workers and every other person involved in treatment of malaria and fever in general about what approach will work and what should not be done, what should be the practice and what should not be practiced. Concerning the data on treated cases that were negative malaria and febrile cases, those who are negative to malaria, who are not malaria, if you read our publications, we fully describe the methodology used there. We actually did PCR and microscopy in addition to RDT. So we did not just conclude that they were negative by stopping at just IAMRAT negative alone. We compared microscopy, PCR, and RDT. So we tested everyone, every single person who participated, every day 1, day 2, day 3, day 7, day 14, day 21, and then day 28, all the way. So, and I think that has answered the question of validation. Then the last question, comment from colleagues from the Ministry of Health, Abuja, concerning the concern about how healthcare providers in the primary facilities will relate with some of the findings and how how we can mitigate the difficulty they have in reading RDT. I can tell you for free that some of the studies that our team have done, and I'm sure Professor Ajayi can also talk about the community-based study they did relating to use of RDT in some part of your state, that this thing just require training and retraining of health workers. That it is not rocket science. Then we also need to make available materials, because the easy excuse is for them to say things are not available in our facilities. The days of relying on microscopy is gone. We should continue to make good use and keep our RDT the way we and follow manufacturers' descriptions. And I want to believe, as policymakers right there in Abuja, we should look in the direction of formulating policies that can aid people to do the right thing And those who are doing well can actually be rewarded, and those who are doing otherwise, we must find a way of getting them back on the right track. I think there's also, okay, I can't remember if there's any part that I've not addressed. Over.
Okay, thank you very much. We have hands up. Professor Falusi is with us. We want to thank all our former directors here at IAMRAT. We have Professor Falusi, Professor Falade.
Professor Chinedu Babalola.
Well, Professor Chinedu Babalola is a former Vice Chancellor of Christland University and our scientist here at the IAMRAT and also advisor. So I will say Professor Falusima, Professor Babalola, and Professor Asinobi. And I know that Professor Falade is also itching to talk. I will try and unmute you, ma. Meanwhile, Professor Falusi, please, you have the floor. Thank you.
Thank you very much for giving me the opportunity. It's been a beautiful lecture, simplified for everybody to understand and getting the point straight across. Thank you very much. I just want to ask you what you think about the effects of the local use of herbs in Nigeria. It used to be, and it's even getting worse with the situation of hospitals now, where people are running away from hospitals and going to all places to get things. In 1997, when we did a study on malaria, 97 to 2000, what we found was that using microscopy, I think we had like 58% positivity for malaria, parasitemia. And on doing some DNA analysis, we were able to find a 20% increase of positivity. And that was how we came out about with our very important publication then on subpatent malaria. Subpatent malaria, which was about 20% across board of those we studied. And our locality was Abanla area. It was specific to Abanla. That was where we used. So,
please mute.
What we found was that there was a 20% across board that was positive, but on microscopy, we could not find it. And then we tried to, at the same time we were doing the study, we tried to correlate this with looking at the local herbs that these children were taking. In fact, we took it, we had a proper section for that. Do you take local herbs? How often do you take it? You know, what volume do you take and all that? Which was recorded, it was a real masterpiece. And we found that there was a very high intake of this local agbo. They even described to us what the constituents were. And then I invited a team in IAMRAT, I think it was, I don't remember who's team, showing me or something, to come along with Professor, the current, he's now in Academy of Medicine, I've forgotten his name now. I've forgotten, it was in malaria unit with Showumi and co. And we invited them to even take these concoctions that they were using and try to help us see what was really in these things that would cause this decrease in the pathology that we were seeing in the labs. So we found that the correlation was very high. And I think we should, those of you in this area of curbing malaria and doing treatment and everything, this was translational enough because it showed us that some of these children were coming to hospital. They were not even, I mean, some were not even coming to hospital. We asked them, how many times were you coming out sick? Many of them were not coming out sick, but there was some parasitemia, which was not coming out in the morphology. I mean, in the microscopy. So this shows us that in the environment where we live in Nigeria, there is a big effect of these local herbs. It tempers the manifestation of these parasites. It doesn't send them to hospital on time, but I think the cumulative effect will be very, very important. That is why when you have some children, they have a 1+. and is already convulsing, is already, giving up. And then you have someone with 3+, and you find that they are still running around, they're still doing very well. So I think the effects of these local herbs should be taken cognizance of when you do your further studies. Besides other ones which you have mentioned, which are really important, it's not only malaria that causes fever, but at the same time, these fevers themselves, we need to find out what is really behind what we are seeing in the hospitals. So the translational aspect is very key. Thank you.
Thank you, ma'am. Professor Babalola.
Yes, thank you very much, Director, our speaker, and all the wonderful people, all the audience. Very interesting correlation I've just heard now, and that has triggered us some research question in my head. Professor Falusi, thank you. Oh, you want me to start video? Okay. You want to see my face? Are you sure I wanted to see my face? All right. So when you were talking, somebody asked a question about simulation. I've just come out of a simulation class. And, therapy simulations are really taking center stage. And I would want you to, as you look into the data, it's very, very possible now to bring in a lot of variables in order to improve therapy. And such variables will include fever, your diagnosis, this drug intake, both for herbal and everything, and bring them together. And there's now what we call pharmacometrics, which can be used to simulate and know how these variables affect treatment outcome, dosages, etc. In Africa, it's a bit more complex, definitely, because of the kind of herbals that people are now taking. And it's much more now, not only with rural people, but with everyone. I mean, I sat near a professor and a fellow of African Academy of Science. He's on his draw, but he's told me that since he started taking one vegetable, he's a retired professor of the science, even a former vice chancellor, that since he started taking that leaf he planted in his compound, his PSA has really, really gone down. You know what I mean? This is a professor, a fellow of both FAS, FAS. So these things have effects. And the earlier we start using them to simulate how it affects those of us in Africa, there is no way some of those people you're talking about wouldn't have taken herbals, many of them. But it's interesting to know that it can reduce. I remember in my master's, I worked on Azadirachta indica. Azadirachta indica will reduce fever and even clear sub-levels of parasites and give you the feeling of being well. Meanwhile, the parasite may be there. So what I'm talking about now is looking at simulations. My second contribution and question is, are we sure that there are no fake medical devices? Because audit is like so available. It's just so available. And everybody is using it in pharmacies, in rural places. They will just show you see the line. You know what I mean? And the rest is story. So how do you look into that? Thank you very much.
Thank you, Prof. Professor Asinobi, please. And please, let's make our comments a bit shorter so that we have other people who have written on the chat. Use the time better.
Thank you very much. I want to thank Professor Orimadegun for that lucid presentation. Excellent. You made it very simple for everyone to understand. And I want to thank Professor Ike Ajayi and the IAMRAT team. And I want to also thank our senior colleagues who are here present, and Professor Babalola, everyone. Ladies and gentlemen, I won't waste your time. While Professor Orimadegun was presenting, I saw that some of, the major thing we are dealing with is fever, and that about 21.6% of them had UTI. What did you do about the UTI? One thinks that malaria parasite can coexist with the UTI, and that may increase their chances of developing acute kidney injury and maybe CKD later. What are we doing about this? Those in the ministry will provide the RDTs. What about urinalysis? What of the strips? Can't we make it? I get worried about these studies because malaria and the complications, which includes acute kidney injury. Malaria and sepsis are the most common causes of acute kidney injury in children. And we don't do anything about it. The ministry leaves it to the nephrologists to handle. So please, when you are doing these studies, I just want to implore you, raise these issues, because it will be incomplete if you just handle those ones. And then at the long run, because we now know that acute kidney injury can progress to acute kidney disease and CKD later. We thought those days that AKI is totally reversible. It's not so. We now know that it's causing CKD. And that's deep inside of me. I'm thinking malaria is contributing to the prevalence of CKD in our environment. It's just that I cannot prove it. I don't have the facilities to prove it. It's a long-term thing, Maybe it may be multifactorial. Now we have detected the genes that predispose to CKD that is more common amongst us. But these things, we should look at the complications also. Thank you very much.
Thank you very much, Professor. Thank you. Yeah. Maybe for our audience, CKD is chronic kidney disease, and AKD is acute kidney injury. Acute kidney injury. Professor Asinobi is a pediatric nephrologist, so I can understand your passion. Maybe before you respond, Professor Falade, are you ready now so I can unmute you? Professor Orimadegun, let me try and unmute.
Okay.
I thank you very much, Director IAMRAT, Professor Orimadegun, my own person, and everybody associated with this presentation. Well done. I just want to drop a few more pieces of information on that study. Every child that was enrolled in that study had blood culture, had urine culture, had viral studies. It was a well-funded study. It was very laborious, but we were happy doing it. And all those who had infections were treated appropriately, bacterial infections were treated appropriately. And we also tried to find out how long it takes for RDT tests, positive RDT, to become negative, because false positivity is an issue. Those with negative RDT tests at enrollment they did very well. We did not have the false positivity was only 5%. But you can understand that because it is a standardized study, we had picked an RDT brand that was top on the FIND study. We only just pretend we don't know what is appropriate. There is a WHO site and WHO committed site and study where available RDTs globally, malaria RDTs globally, are deposited, and WHO funds the testing in specifically identified laboratories In Nigeria, we are lucky to have one of those laboratories in Unilag. And Professor, oh my God, he'll be mad at me that I can't remember his name.
Wellington.
Professor Ibo is the principal investigator. And so having picked a reliable malaria RDT, which is, you have to do good laboratory and good clinical practice for clinical trials. And so we are very comfortable and confident with the results. All children who had bacterial infections were treated. I will also like to comment on the traditional herbs. I was part of the malaria lab or malaria research group when it was at its peak. And in collaboration in a multidisciplinary study where Professor Edith Ajayoba was PI, we spent 2-3 years in Okeogun area, cutting traditional healers and monitoring their work. We actually carried out a clinical trial on their herbal preparations. Interestingly enough, the traditional healers had areas of specialization. So we concentrated on those who specialized on fever, on childhood fever cases. We had laboratory work, we had in vitro culture and sensitivity. We did a lot of studies, but I'm zoning in on the clinical trial now. We found out that many of them did not have antiplasmodial properties. A significant proportion did have anti-inflammatory properties. And we had built it into the study from the beginning that if any child deteriorates, we'll take over to avoid any substandard herbal preparation. We made them prepare their herbal preparations and we made them administer it. We just insisted that they give us the contents to guide our laboratory studies. The one preparation that we found very efficacious was from cotton seeds. But unfortunately, that had infertility, depression of spermatogenesis side effects. And while I believe that the anti-inflammatory properties reduce the presentation, might have been involved in reducing the presentation of children with fever, I'll also like to state that the presence or the density of malaria parasites in the circulation is actually not a reflection of the burden or the part of the parasite load in the body. With the result that a child can come in smiling, playing, having had a transient fever, but under your nose, if there's a sudden release of parasites into the circulation, that child can convulse. And yet your parasite count 3 hours earlier, which you are still trying to read, may be very low or even not available. And so we must be careful about how much weight we put on the herbal preparations. Anecdotal reports actually do not hold a whole lot of weight in clinical trial outcomes. Like the PSA, if somebody is on treatment and the PSA is going down, and it doesn't say it is the herb. I thank you for giving me the opportunity to say a few things. Thank you.
Thank you. It seems that Professor Falade has addressed some of the questions. But before you continue, Professor Orimadegun, there is one question in the chat here. It says, how feasible will any policy from this translational research be in a low resource settings, bearing in mind the problem of affordability and accessibility? Will this not necessitate empirical treatment? Who else has his or hands up? Dr. Majo, I saw you. I hope you are still with us. I pen you down. If you are still with us, please unmute and ask your question or contribute. She also was at the National Malaria Elimination Program. She was called Mama Malaria, and she was a national coordinator for some years. Mama Malaria, are you still with us, please? Sorry, I'm calling you a bit late, but I have it penned down. Okay, so Professor Orimadegun, address others, then I'll do some recognition and then we close the session. Thank you.
Thank you very much, ma'am. I appreciate everyone that has spoken this evening. I think my mentor, Professor Ketrifalade, has addressed many of the questions relating to malaria and the issue, but a few left for me to handle. Thank you, ma'am. I would like to make a comment about the simulation issue. Professor Chinedu Adebola, thank you very much. That is a very good direction to look at. And these days of artificial intelligence, they can actually take advantage. For example, those of us from this part of the world where we have limited access to funding, we can go back to our clinical data and bring out information that we know are reliable, that we can feed into modeling to simulate, and then we can do prediction, as they say. I had an experience recently. I wrote a proposal to TED Fund. I wanted to use AI to build an algorithm using machine learning concerned to make a decision between malaria fever and non-malaria fever. Unfortunately, it was not founded. Perhaps they did not understand where I was going, or maybe I did not communicate effectively enough. But again, that brings me to another point I would like to say at a forum like this. For all of us, let us be advocates for local funding. Malaria, for instance, is becoming a local problem, Nigerian problem, mainly. And with time, if Prof comes through with his threat to withdraw aid completely, we may find out that we will have resurgence of many diseases, not only malaria. So our leaders, we must begin to think of how to fund research locally. And let us be advocates anytime we have the opportunity to talk about it. A little percentage of income from Nigeria here and there will go a long way in supporting upcoming and young researchers and do good translational research. In terms of fake RDT, I think Professor Valade has addressed that issue, that we got our RDT from validated and valid sources. And it's true that there are so many fake diagnostic devices out there, but there are those recommended. So we need to educate ourselves on how to recognize the correct diagnostic or recommended diagnostic kits. Trust Nigerians. People put their money where they can get quick profits. And the moment they realize that what is moving in the market now is RDT, everybody will go to the market and start buying. Some will even adulterate it. Professor Asinobi, I could feel your passion when you are talking. And talking about UTI and malaria. Just like Professor Valade said, we tried to treat every case based on what we found on investigation. And believe me, we did not go beyond uncomplicated malaria. So we were almost sure that none of those cases that we treated or enrolled could have progressed to developing CKD in the future. But perhaps a further research on that will be necessary. And concerning your hypothesis of malaria contributing to CKD, I'll be willing to do a systematic review with you. You can check to know. Okay, local herbs, that has also been traced very well. I acknowledge and appreciate Professor Falusi for that contribution. I'm grateful to you all for the opportunity given to me. Thank you.
Wow, thank you very much. It's been a very, very worthwhile long day. But before we go, I cannot but still recognize some of our people here, all our former directors. We're very happy that you could join us. The NMEP group, I know, Mr. Eze, you were going to say something. Are you still with us? Can you unmute and give us your goodwill message? Maybe they've gone into another meeting, ministry. Mr. Eze, please. Okay. I've recognized Dr. Majo, and also we have the WHO person with us. We have Adebola Moses. We have who else? Many professors who have joined us. We have our friends from the different universities. I could see FUTA, Lagos, Ibadan here, our colleagues. We want to appreciate everybody who has been with us. And we say that we are happy that you could make it, and that you should please look forward to another interesting time, interesting lecture coming up next month. In fact, you should just be on the lookout. And I want to thank the IAMRAT team for putting this together. It's actually always very interesting the way we get our lecturers, and we are very, very, very happy when they come and present beautifully. And to the lecturer of the day, Professor Orimadegun, we cannot thank you enough. We are very grateful. Despite your busy schedule, you still gave us this very brilliant and very useful lecture too. And we hope that you'll be able to do the systematic review. And also, we would like more collaboration with IAMRAT in your future work. You know that funds are difficult to get. So if you get your fund, please come to IAMRAT. We are here for you to support and collaborate. I think we can call it a day now. Please, if I omit recognizing you, like I said, I recognize everybody here, all of our lecturers, our friends of IAMRAT, friends of malaria research, and all others from different parts of the country. Mr. Chukwu, you are still with us. Were you going to say something from NMEP, final word before we close? Mr. Nelson isn't here again. Mr. Chukwu, sir.
Thank you very much.
Sorry, Mr. Chukwu, let me recognize Patrick Nguku. Patrick Nguku, he's a top executive with the AFENET, and there's the African Field Epidemiology Network. He has actually collaborated a lot with the University of Ibadan, especially the Department of Epidemiology and Medical Statistics, where we actually started the NFLT program that's now cumulated into the Nigerian Center for Diseases Control. So, Oga Patrick, are you there with us? Do you want to say something? Any goodwill message from AFENET? Okay, so
just to say thank you.
Oh, I'm so happy you could make it. Thank you very much. And please consider collaboration and so on. I know a lot is happening at AFENET, and we are here to also collaborate with you. So final words from Mr. Chukwu.
So thank you very much for that, organizing this lecture, and to the person that delivered the presentation. Wow, great work. And we look forward to utilizing some of the outcomes of this research. We hope they'll be translated into policy, and we can see that happen, have effect upon the control programs, elimination programs that we are running here. Thank you very much, sir.
Thank you very much. And I say thank you very much to everybody. Have a good evening. And I will look forward to seeing you next month. Thank you. Please remember to register using the link provided. I'll put it again just for those who have not. Just go there and register and indicate if you want the CME or points so we can send it to you. Thank you very much, everyone.
Hold on, you are.
Thank you very much, Director. Thank you.
Thank you, ma. Thank you, ma.
Our lecturer, appreciate you. Thank you for inviting us. Bye.
Thank you. Bye, ma. Bye-bye, ma.